Anybody's logged on publicly?
She works with Steve McCaffrey.
Who does? Oh, okay, do we have any public people on here?
No. Media is. Oh,
Oh, it is.
yeah.
Okay.
I honestly. What? Okay, that's a conversation behind the. We're looking at things.
Well, it's Ed's coming. Do you have any idea how long it will take Senator Pro?
Boston, Salt Lake, Savannah.
Well, we're waiting a few minutes.
Hi, good afternoon. We're going to wait a few minutes to get started to allow more time for members to arrive.
Hi, Kelly. We're the only ones sitting.
I know.
We're giving them a couple more minutes. Should just turn around. There's our meeting. Sorry, I was back to back on meetings. I was like, remind me to leave this one a little early, and I didn't allow enough time. Oh, she brought my jacket. Yeah, I started I don't have enough. They laugh at me because I always have a jacket or. I usually, and I thought it's gonna be so hot today and we're not gonna be cold. And then they rolled my car and I just. Secretary Rowe makes fun of me. He goes, "Are you cold?" I'm like, "It's cold in here." Well, we know Representative Claire is coming, he's running late. We have Stephanie Anderson is on in, and Aaron asked me to run the meeting. Yes.
Yeah.
Since our chair and vice chair aren't here. Well, Aaron, why don't we go ahead? Okay, could we close the doors, please? Thank you.
Wait, is this? But it's not just hot.
Then I don't take your jacket off. I had a jacket upstairs tonight. It was a little warmer in the conference room upstairs.
Yeah. Okay, everyone, I think we'll go ahead and get started. We know Representative Claire's coming. We may have a few other people jump on here virtually. I'm Joanne Burke, and this is not the Commission on Aging, but our chair and vice chair of the Choice Board are not able to be here this afternoon, and I do sit on the Choice Board as a member. And I've been asked to chair the meeting, so that's what I'll do this afternoon. So let's call the Choice Board to order. And Aaron, you're going to talk about House Enrolled Act 1391.
Yes. Okay, can we flip flop the agenda to have Stephanie go
First,
just because I think
okay,
Representative Clear should be here for the.
that would make sense. Okay, Stephanie,
I didn't hear.
She's in my house, sorry.
Well, good afternoon, everyone. My name is Stephanie Lasky. I'm a project manager on Aaron's team. And one of the projects that I've been working on in the last couple of months has been a new direction, I guess, of the Choice Self-Direction Policy Manual. So for those unfamiliar with this particular program, Participants in the choice program can receive self-directed attendant care, but there has not been consistent implementation of this particular practice across the AAA network. So we set forth to really standardize what the self-directed attendant care policies would look like. So we created roughly 15 to 20 page manual that really outlines the program overview and eligibility requirements. It highlights key policies and procedures with the goal of really, like I said, ensuring consistent program delivery across the state. At this point, there are only 3 individuals in 2 AAA service areas who use the attendant care self-direction program, but it's becoming more and more popular on the waiver side of things. So we anticipate it becoming more popular on the choice and other non-waiver services as well, hence wanting to kind of build the plane before we needed to fly it. So one of the key differences in self-directed programs is that the participant has a lot more responsibilities than they have in a traditional attendant care program where they choose a company that hires attendant care providers and they don't really have a lot of say. So with that freedom comes some additional responsibilities, which would include recruiting, interviewing, training, supervising, and evaluating their personal service attendant. This sounds heavy, and we'll get into some resources that we created to help older Hoosiers through this process a little bit later in the slide deck. Ultimately, a lot of folks are choosing to hire friends and family members, so we wanted to make this as least onerous as possible on those individuals. Individuals who participate in self-directed care are also responsible for managing the financial aspects of their care, so they are given a monthly budget of how much they can spend on their attendant care services, and it's really up to them within the guidelines of Indiana code to budget what they want to pay their attendant care providers. They have a little bit more flexibility. They also have to ensure a safe working environment and compliance with the program guidelines. So just as a company would be responsible for things like OSHA enforcement, these individuals are responsible for ensuring a safe working environment for their staff. If a participant is unable to self-direct their care for any reason, a representative that meets certain criteria may assist them. So if they are struggling to implement this on their own, they can have assistance from usually a legally responsible individual who's helping them. Next slide. So the personal service assistant or personal service aide registration, that individual must register with the Division of Aging. So the individual hired by the choice participant does need to register with the Division of Aging as an aide. They must not be a legally responsible relative of the participant. And right now they do need to become a Medicaid waiver attendant care provider. We're looking into policies and procedures, you know, as we talk about the new House Enrolled Act as well, to kind of see what that looks like in the future. But at the moment, they do need to become a Medicaid waiver attendant care provider. Next slide. We did work with our Office of General Counsel to exempt these personal service aides from certain insurance requirements that would normally be required for Medicaid waiver providers. Specifically, those insurance requirements related to property damage, injury, or loss of life to the participant. Again, so many people choose their grandchild or their niece or nephew or somebody like that to care for them. It seems onerous to require an individual to carry that level of insurance that a normal company would provide. We do have information in the new manual coaching choice participants to carefully consider the ramifications of hiring someone without this type of insurance. What would happen if they were injured while their aide was caring for them? If the aide does not have insurance, who's going to pay for those damages, that kind of thing. So we do provide some resources for folks to consider, but we are exempting if the aide chooses to exempt themselves from having that level of insurance. Next slide. AAAs are encouraged to provide training and ongoing support to all choice participants, and they must implement monitoring and quality assurance measures to ensure that the program is working effectively. So again, this burden falls to the AAAs, not the individuals participating in the choice program. Next slide. In terms of compliance with regulations, the burden again falls to the AAAs. They must ensure that all aspects of the self-directed care program comply with relevant statutes and administrative code. We have laid out a lot of guidelines in this manual for the AAAs to ensure that their program is following all of these relevant statutes and codes. Next slide. Fiscal intermediary, this was an area where we found some variation among the individuals currently using the Choice Self-Directed Program. So we did create a policy that says that individuals must use a fiscal intermediary to ensure compliance with all fiscal aspects of the program. So this would be usually a private corporation that manages the payroll, the HR aspects of the program, ensuring that relevant taxes are removed from paychecks, all of those kinds of things. Currently, as I mentioned, there's only 2 AAAs implementing this program. One AAA uses a contracted fiscal intermediary, and the other AAA serves as the fiscal intermediary for their participant. We are going to encourage that AAAs contract with a third-party fiscal intermediary rather than serve as that FI, just to remove any conflicts of interest, but per code, we can't require it at this time. In terms of documentation and reporting, this is fairly standard for a lot of the case management that AAAs perform for our Choice clients anyways. They need to maintain detailed records of assessments, care plans, and services provided. They must report program outcomes and any incidents that occur during the program implementation, and they have to ensure confidentiality and secure storage of participant information. So nothing new or onerous on the AAAs. This is all stuff that they do as part of their case management anyways. Slide. Similarly, they should engage in continuous improvement efforts to enhance the self-directed care program. They can do this through the use of staff evaluations that we'll talk about in a moment. They can do this through quality satisfaction surveys, all kinds of different methods that they can use, but they should be engaged in that continuous improvement to make sure that the program is meeting the needs of these Hoosiers. Next slide. And then finally, the resources I mentioned earlier that we provided in this manual to reduce the burden on individuals who want to participate and want to direct their own care. We gave a sample job description, interview guide, letter of reference, because there are 3 letters of reference required to register with the Division of Aging as an attendant care provider on the self-directed program. A budget worksheet to help folks understand what the implications are of paying their PSA a higher rate. They might get fewer hours than what they're qualified to receive. And then a sample performance review. Again, if you're hiring a family member like a grandchild or niece or nephew, reviewing their performance can feel very uncomfortable. So we wanted to give them sort of a template to work off of so that it was a little bit more objective and a little bit less onerous on the participants. Any questions? Thank you.
Thank you so much. It does seem that will pick up and you'll get more people using it. Okay. Representative Claire, I was asked to chair this meeting because our chair and vice chair aren't here, so that's why you're not at the Commission on Aging where I usually chair.
Well, glad you are here and willing to chair.
Okay. And we have Stephanie Anderson is on, right, Stephanie? Hello.
Yes, I am here. It's just hard to watch and be on video at the same time.
Okay, thank you so much. And do we have anyone else online? No. Okay. Small
Stephanie?
group, but we're here.
Stephanie's the only person online? Okay.
Okay. Well, all right. Erin, you have an update for us?
Well, she's the only person online in the meeting, but aren't there other people online through the YouTube channel?
Yes.
Yes.
Right. Yeah.
Today we're going to talk about House Enrolled Act 1391. This will be referenced as Public Law 167, 2025. And Representative Clear has referred to it as Choice 3.0. So as.
Why not?
Why not? You're not aware, Representative Clear authored this bill and was really instrumental in its passage along with I4A and others, and we really appreciate the collaboration with us throughout this process. So thank you for that. Before, I'm going to go through the various aspects of the bill, but before I get into that, is there anything that you would like to say before we get started?
Well, we had a lot of stakeholders and other supporters. We're going to hear from I4A, from Hannah Carlock later in the meeting, and Hannah was certainly instrumental, as were you, if unofficially, as I've said privately to you and publicly, since you took ownership of the Choice Annual Report several years ago. It's really turned into something very useful for a lot of purposes, including policymaking. And it certainly helped inform our discussion around choice. And I remember telling the secretary how much I appreciated the work you've done on the annual report, which I think he read. So, so good work. But no, it's a lot of people involved in not only getting this across the finish line in the legislature, but in crafting the bill along the way, because it underwent a lot of changes from its introduction to its final passage. And there were a lot of good changes that made it a stronger bill. I know you're going to talk about things like the decoupling, and that's one example of something that was made better as we worked through the process with, Kelly and you and the rest of the team from FSSA and I4A and the other stakeholders. So appreciate your work and looking forward to your presentation.
Thank you. So I'm hoping that we can have some discussion today. If not with the small group, we can just maybe throw out some ideas to further discuss at our next meeting in July. I will send out the link to the bill. It's not officially listed in statute yet until July, but I'll send out the bill for those that would like to read it in more detail. Yeah. So one of the pretty significant updates to the choice statute has to do with the choice services. And currently the choice services that are provided through the program are options through the program, in a lot of ways mirror services that are available on the waiver. Not all waiver services, but there are quite a few. And then there are some that are only Older Americans Act services, such as handy chore, a little bit of congregate meals. The Act expanded the definition of other services. It used to be other services necessary to prevent institutionalization of eligible individuals, and the updated language expanded it to prevent and reduce hospitalization and institutionalization and the need for Medicaid home and community-based services. So for a long time, choice has been viewed in some ways as a bridge to the waiver. So with this updated language, it really tries to refocus it on not necessarily as that bridge, but really being a diversion away from Medicaid home and community-based waivers. The Act also added support services that provide education resources and strategies to help caregivers and family members of individuals with dementia. And I think this really aligns with the Division of Aging's efforts related to the statewide dementia strategic plan and the implementation of the dementia care specialist program. And it's not really something that has been a focus of choice in the past. So similarly, there is updated language regarding the program funding priorities. New language was added about identifying individuals who are at risk for impairment with respect to ADLs. In Choice 2.0, the statute was updated to include eligibility for individuals with 0 to 1 ADLs who are at risk for institutionalization. This kind of broadens it in a way to be at risk for impairment related to those ADLs, individuals eligible for the program and not eligible to receive Medicaid. Currently, and I meant to look at the number and I didn't, but I think it's about 60% of the individuals that were reported in the Choice annual report last year have Medicaid. Doesn't mean that they're eligible for the waiver ever, but they currently are in Medicaid or have Medicaid while receiving Choice services. Like it's possessed a little bit. You can go back one more. Thank you. Also provide community and home care services to individuals described in above. So this new population or populations that we will be targeting with the Choice dollars going forward for the purpose of preventing and reducing hospitalizations and institutionalization. And again, that need for Medicaid home and community-based services. So that concept of the Medicaid diversion. So I was hoping to have some conversation today about what that might look like what kind of services when you are thinking about if we want to prevent and reduce hospitalizations and institutionalizations. You know, we know that there's the attendant care and the home modifications and the handy chore that are available through Choice. With this kind of broadened scope or focus, what new services should we be thinking about?
Were you wanting to pause and talk about that?
I was. It's been a long day. Community health workers, okay.
Can you bounce back to one slide? Go back up.
Can I ask a question?
Sure.
May I ask a question? So when I see, I think I know PERS, the personal emergency
Mhm.
response system, is that what I think of? Like, where I can press a button?
Yes.
However that is,
Mhm.
whatever the company is, there's a
Yes,
large.
monthly monitoring.
Not what Kelly Mitchell would refer to as remote supports, or that could be, I have access to a caregiver via telephone, virtual, whatever, that may be 20 minutes away, but so does Dr. Burke, because we live within certain miles. Is that available now through Choice? I don't see it.
Mm-mm.
So I would plant that seed, and you made me think of this earlier. And actually, Lisa and I were having a conversation pre-Commission of Aging. I think one of the things is we have to think about being much more innovative when we're thinking about our current economic climate, both nationally, statewide, but and I'm part of it, the silver tsunami, right? I'm the tail end. There are going to be more people than we have bodies to care for, regardless of money. And there's a lot of really interesting studies about how we can support individuals to age in their neighborhoods, in their communities, but it's by using these concepts, not in a developed assisted living community, but how do we leverage connectivities and shared supports within communities, neighborhoods, what have you. So I would just drop that little nugget. This might be a wonderful place to explore that thought if it's a possibility.
I have a related word. You said innovative, I think, when Aaron and I were talking a week or so ago in preparation for this meeting. I believe I used the word entrepreneurial. I think we need especially as you point out, in this difficult fiscal time, we need the AAAs and other stakeholders to be not only innovative, but entrepreneurial, looking at ways to stretch the funding and think about and approach things in completely new ways. And I think a lot of that, I don't want to get ahead of you, Aaron, in your presentation, so cut me off if I do, but I think outreach and education are going to be major components if we are to be successful with Choice 3.0. And if somebody has a better label than Choice 3.0, I'm all ears. Hannah's back there shaking her head, which she often does. But
I say, I think.
But you know, the other word I used when we were working on Choice 2.0 was choice modernization. And I think I know this is a continuation of choice modernization. And I think Choice 2.0 set the stage for this, as Aaron said, with the ability to use choice for at-risk individuals who don't yet have impairment of 2 or more ADLs, but rather have impairment of only 1 or no impairment, but have been identified as being at risk of losing their independence. And that's where the AAAs come in, is identifying people who are at risk. One of my ideas that I'm certainly not married to, but I've talked with Hannah about it. I've mentioned it, I think, to Aaron, and it's the way that I hope we will start thinking about this in my area, and I suspect this is true throughout the state. We have senior discount day at local grocery stores. Kroger, in this case, has a day when seniors can shop and save some money and receive some special attention. And I see you nodding your head, so it's something you're familiar with. And so I think that's something that we haven't taken advantage of, at least in my area, in the past. And I think there's a tremendous opportunity, because everyone who is taking advantage of that senior discount day is a senior. They're all still independent because they're grocery shopping, and probably every single one of them is very concerned with maintaining their independence. So it is, as many people would say, a target-rich environment. And I think, it's some of this innovative and entrepreneurial approach is as simple as identifying opportunities such as that, creating partnerships, with grocery stores and other community entities to simply set up a table and provide information and do on the spot counseling, outreach, whatever you want to call it, to help folks understand what's available and how it could help them maintain their independence. And that's how we pivot to a more preventive approach. Instead of waiting until someone has an illness or an injury that threatens their independence, we identify them prior to that as being at risk, and hopefully prevent that illness or that injury, the medication mix-up, whatever may cause them to lose their independence, prevent that from happening. So I don't know that there is any. I know there's not any one thing. I think it's a lot of things, and I think it's becoming more innovative and entrepreneurial. Dr. Burke, do you have any
Well, I
thoughts?
think I'd like to recruit.
Scoot up to
you
your
to
microphone,
study
Dr.
longer.
Burke. Dr. Burke. Scoot.
To the Commission on Aging, we were talking about that this morning. I mean, I don't want to use this term, with policy devolution, we moved from federal and state programs more to the local community, the families
Yes.
and local community getting more involved in proactive initiatives. You know, this is wonderful with choice in that I was frankly concerned. I mean, all of you did a lot of work in this legislative session to get this over because, you know, it would be easy to say, oh, well, we don't need choice. We got Medicaid waiver. Well, but we don't want to spend money on Medicaid. Well, now we got a problem. Well, this is a very positive response to that. And I was saying this morning, you know, unfortunately, kind of what people got accustomed to was, well, we just go to the nursing home and we put people in the nursing home to apply for Medicaid if they can't pay privately. And we lost some things along the way. I mean, when my grandparents, you know, we took care of my grandparents, that was a long time ago. We didn't have Medicare and Medicaid.
Mhm.
And while that's been very helpful in many years, we sort of lost some other pieces of this. Now, I will tell you, there's a segment I'm really concerned about with the population, and that is the segment who have no families. I don't know quite what we have to help families understand and get educated on this is not institutionalization now. It's keeping people at home and protecting as much as you and providing as much as you can. I'm not sure what I don't think our local communities quite have this yet, but we've got people that don't have families who can't, won't, or don't help with them. And that's a group that some of which don't have, some of them don't have real good social relationships. What can I say? They have some impairments that don't permit them to do that. But we've got those people in our local communities too, and that's a little bit, I'm not sure where they're going to go with this. You can do some things with some of these preventive things, but we are down more at the local level than we have ever been, and this is a real step forward in terms of, I think, helping to promote some initiatives within local communities. That's what you're talking about. I don't know how much local communities are quite seeing this yet, but that's where we are.
And I sit here too, I think, as I think about it, you know, from the purview of the state and some of the responsibility on us. Speaking to really how do we build that capacity, if you will, in our local communities. And I know we're speaking specifically of choice, but as I'm looking right at you, I'm sitting here and I'm thinking about, we have a dementia care program, which what is the focus? Creating communities, right? Bring in private sector to create communities that are supportive of families, of individuals who are, you know, with dementia, so that they can age in place as long as possible. We need to be leveraging these pieces. They're not siloed. I realize there's the focus on dementia care, but you're bringing those entities together and working on collaboration. And this is really about design of community, connecting, how do we market, educate. So it really is, and you know, we're getting ready to move into a strategic planning process, you know, within the division. And I think we have to think about and ensure that we're not looking at everything siloed. So where might we leverage? And I'm thinking about our multi-sector plan on aging, because we're getting really excited about that again. Not looking at these things as separate. Like, we're doing this now. We're doing this now. It really is about, they all don't get excited, building communities that are going to let Kelly Mitchell stay at home as long as she wants to do all the fun things that she likes to do, right? Because I'm there, I'm already thinking about it. I don't want to move. I want to do X, Y, and Z.
Right, absolutely. Well, and I think another part of innovation and entrepreneurism on the part of the AAAs is looking for other partnership opportunities in the community, in the local communities they serve, which is one of the places where AAAs are uniquely positioned because they know the communities they serve and they have the ability to go out and find partners with or without funding. I mean, you know, some partnerships may come with grants, other partnerships may be community organizations that that want to be involved. I know, again, I don't want to take away from Erin's presentation. She's going to talk about the decoupling, and when we get to that, that opens up all kinds of community opportunities. We have in my area a retired senior volunteer program that has a team of retirees who like to build ramps. Well, now they'll be able to build ramps, you know, for choice recipients as a result of the decoupling, rather than spending, you know, $10,000 for a ramp. The AAA may be able to get the ramp built for the cost of materials because there are volunteers in the community who would love to work with the AAA to help seniors stay at home. So I think there are just all kinds of opportunities, and yeah, I'm confident the AAAs will rise to the occasion. I hope Stephanie's hearing us okay. I can see her. I see her shaking her head on camera. Stephanie.
I'd be there in person. I have pneumonia, and so I didn't think I should bring that, but I am definitely listening and hearing.
Any thoughts from you on any of this?
I mean, I'm really trying to relate it back to my area, which is mental health, and trying to understand how we can better capture folks that have chronic mental illness as they age. In particular, I know with the CCBHC model and expanding into that CCBHC model, we're looking at more upfront crisis care and preventative care, getting people access to care sooner in the mental health forum. But I don't know that there's a whole lot of cross-pollinated knowledge between those that work in the mental health field and what's available for their clients as they age in terms of these types of services. And so that I see as a really big opportunity. And the CCBHCs would be a great place to start in terms of making that connection for folks. Sorry.
If you get to feeling better, I think behavioral health has all kinds of opportunities, and so does disability. I see Tom Krishan from the Arc of Indiana in the back of the room, and if we can get going with gubernatorial appointments at some point, Tom will be maybe sitting here at the table as a member of the Choice Board, representing individuals with disabilities and organizations that advocate for individuals with disabilities. But the disability is something we've talked about more here at these Choice Board meetings in recent years. And as with behavioral health, I think there is an opportunity to find a lot of opportunities and connections and synergies. You know, the ARC has chapters throughout the state, and that's another potential community partner for the AAAs.
You know, this morning, I was listening to one of our local TV stations, and they were interviewing, I believe it was a Henry County sheriff, who was talking about the increase in the number of people that they are getting with not just serious and persistent mental illness that they end up having to go out and deal with because people are agitated, but also people with dementia. Now that is just, this is really the wrong place for these folks. And I don't know how a choice program getting to some of these folks and getting them some assistance before they would be put in jail. I mean, that is just, I wanted to sit there and cry this morning. I thought this is just the wrong place. And that's a local community just not knowing what to do with these people.
Mm-hmm.
And we don't have a real good answer here, but they know they can't handle this. A homeless shelter isn't the best place for it. We talked about some of the needs for emergency housing this morning, but it's kind of beyond it, just, what we think of as the behavioral health population. We got older people with dementia being locked up in jail because they have behavioral problems and they're going in. I mean, there's lots of things we can probably begin to think about. What can we do to assist our local people who are trying to deal with these issues? That's like the last resort when they get picked up by the police and taken to a jail. And I don't know, we may have to keep an eye on that. He's saying that's really, they're seeing more of that. And that's really of concern.
Well, I think you raise a great point, and going back to, Aaron's point about how do we put this into action. There's another opportunity for partnerships, AAAs to partner with local law enforcement, police agencies, to increase awareness, possibly partner on some training. Again, I think there are synergies here because I'll mention the ARC again. They've done a lot of great work over the years to try to increase awareness among law enforcement when it comes to people with disabilities who may be wrongly perceived in a law enforcement situation where an officer arrives on the scene and perceives behavior as being non-compliant, for example, rather than simply reflecting a communication barrier. And I think we're talking about some of the same things with dementia. And with that, there are certainly opportunities for partnerships. I think, to be very blunt, the loss of the move from the A&D waiver to the pathways waiver and the resulting loss of A&D case management has been a real blow to the AAAs, but it's also created this opportunity to focus on the choice program and do things that we weren't doing or haven't been doing up to this point. So I'm excited about it. But Aaron, I didn't mean to take away from your slides.
Conversation. So you mentioned the Choice Annual Report earlier. So thinking ahead, what would success look like? Just what would, the annual report goes to the legislature, goes to you as the board. What would you all expect to see, like to see, hope to see in an annual report as far as success measures, outcome measures, questions to answer? Because I think as we are, and we'll be working with the AAAs on implementation of this, but as we are thinking about what this might look like, I want to, from the beginning, think about, okay, what are we trying to really do and say and tell the story?
I think you already do. I mean, I'm looking at, I think you do some of it, but. And I don't exactly know how to quantify this, but I'm looking at that bullet point, preventing and reducing hospitalizations. Reducing the need, that movement in, like my ADL needs have increased to the point I now qualify for waiver. So are we, through what we're doing, whatever it is, services, are we seeing that the individuals, be impacting them in a positive way? Are we seeing either a level set or reduction in visits to the emergency room or hospitalizations? Are we seeing a lengthened period of time where people are remaining in their homes, supported in their homes via this versus movement to waiver or institution? I know that we do that to some extent, but I don't know that we fully look at that and you can really paint that picture, because that to me is, I'm thinking about, why are we doing this? Because if that's not happening, right?
Well, I think Aaron's finally put us in a position where we can start to look at those things on a longitudinal basis because we didn't used to have the data. Right. So Aaron's put us in that position. I'm going to use my grocery store example again. I think it's really important, or it will be really important to track those activities and what results from those activities. So, I want it to be, meaningful and, standardized. I guess I would use those two words, Aaron. I think, and when I say meaningful, I'm not interested in just blowing up the numbers for the sake of blowing up the numbers that, we talk to, 4,000 people over the course of the year at the grocery store. We gave away, stress balls or whatever. What I'm getting at when I say meaningful and standardized is I think maybe the division, or what do we call it now?
Still a division.
Is it? Okay. It's all kind of together though, right?
It is.
Yeah.
I mean, we're collaborating.
Yeah.
Lisa's probably sitting on there really excited because we were just really kind of talking about this earlier.
Yeah.
I'm not interested in how many people you talk to or how many phone calls you made,
Right.
if they don't result in anything. The act doesn't mean anything.
That's right. So
are you seeing?
yeah, I'm just giving you a hard time about the division, but I mean, whatever we're calling it. Yeah. Whatever we call it, however it works internally, I think there needs to be some standardization, as to how do you document a contact. Now, I don't want to create layers of bureaucracy and work for the AAAs, but I think it's more than just giving out a stress ball or a bag or some, little goodie to somebody who stops by the table. It's capturing information and then doing follow-up that leads to something. And maybe the something is realizing that person is not at risk right now, but they're going to be receiving ongoing communication to remind them of what's available if their circumstances start to change over time. But particularly for those individuals who are identified as being at risk, then it's, what are the follow-up activities? I think, one of the lowest hanging pieces of fruit, and somebody tell me if this is not how it should work. This is how I've explained it ever since Choice 2.0. So I hope I've been explaining it correctly. One of the things the AAA could do is send someone out using choice funds to evaluate the person's home for fall hazards and other risks. And I think a lot of times we've talked about that being an occupational therapist as an appropriate person to do that evaluation. So I think that when I talk about meaningful and standardized, I think, every contact, whether it's at the grocery store or some other setting, some other community setting, and this hopefully is going to be AAA's doing outreach to, civic organizations and churches and at fairs and festivals and things like that, but capturing information and then doing follow-up that in many cases may result in a home evaluation, and then that could lead to home modification or other services. But getting back to the report, I think the report is doing a really good job of describing and quantifying what Choice is doing. I think your newest challenge, Aaron, with the report is going to be to describe and quantify what Choice and Medicaid are not doing. So, for example, we're going to have to start reporting on the number of individuals with whom the AAAs have had meaningful and standardized contact that has led to, for example, a home evaluation where a risk was identified and mitigated or abated. And then that person doesn't need choice services, and they certainly don't need Medicaid services. So So I think there's a challenge in tracking that because you're tracking over time things that aren't happening, right? Because part of my vision has been for Choice to serve people on a one-time or limited time basis for prevention. And then the person may not need ongoing services, maybe some case management check-ins over time. But hopefully we're catching people early enough and identifying the risk that we can mitigate or abate that risk. And then they can go on living happily without having services every month for a period of months or years. And at some future point, because that relationship exists and because the communication is ongoing, the individual may raise their hand and say, hey, I think I need some help. And then we can help them again, maybe at that point with monthly or weekly services. So you see where I'm going.
I got a little bit excited about that because really talking about something similar actually in kind of Medicaid waiver world. I think we always get into our mindset, someone's purchasing a service, doing whatever, and it's ongoing every week, every month. And that would be something else innovative, looking at this differently to the point you're making. I come to you, I have a need now, and perhaps it is maybe an assessment, a home modification, maybe I get a little bit of something, some therapeutic service. I don't need that every month,
Right.
but what happens is we put a budget in place, I use it. Sometimes, honestly, we create dependence
Mhm.
rather than fostering independence. But, and then, so that would be a means of, I still care coordinate, but for that individual, but not maybe actively intervening.
Mhm.
So looking at how long does that happen? And but I can have access to service when I need it.
Mhm.
There's the challenge.
I'm just over here, just boiling to share.
When you come up to a microphone, if it's appropriate, but. Well, there are folks online. Well, first we need Dr. Burke to say it's okay for you to speak.
Yes, we're in a wonderful conversation this afternoon. Just please introduce yourself.
Okay, hello, I'm Lisa Schneekopf and I am the CEO at Socoa Aging and In-Home Solutions. And we're talking about interventions that make a difference, that reduce hospitalizations. To see that being added to the language of choice is so exciting.
Yeah.
Because currently we are working the impact model at Socoa for the community health worker program. And we have data from the study that we did with Purdue that shows 64% reduction in hospitalizations. We have the data already with a program that does that short-term intervention, identifies folks on the front end, and it's a quick, making the referrals, et cetera. And I would be so thrilled if that would be considered for one of the choice services. And we would also be very happy to come, if allowed, at the next meeting in July and actually present on what we're doing. Very brief, but it would be a worthwhile experience, I think. So
I think,
Excuse me.
I'm circling back to kind of reports and the metrics and how we measure things. I don't think it's just the opportunity here, it's the opportunity as we look at, and particularly in our current environment, but you may spend money here to this point in choice. And it reduces cost over here. And if I'm only looking through my, my blinders here, I'm only looking at the cost of, let's just use choice. This is what it's costing. We're spending X on choice. But if I'm saying 15 I'm going to make it easy on me. 15 individuals got choice services when they entered. Hospitalizations were at an average cost of and after the impact of choice services, now they're reduced. That's state and federal dollars saved,
overall savings for sure.
right? Maybe not choice dollars. And I think that's where we as a society, oftentimes we, and we deal with our own programs. And that's why I keep saying we have to look across the all and how we're leveraging these pieces. But then when we report, we have to think in that way.
Well, if we have a wonderful opportunity for some things to come together, I think right now in Indiana. What these changes in the choice program, along with going back to the multi-sector plan on aging. Our communities just simply, we have more people living longer than ever before, and we haven't really adapted to what we're doing
Right.
at a local level
We have not.
to address this. And all of these things, including the community health workers, all bring these things into play at the local level. So our reports need to possibly be not just individually focused, but
Yes.
also include some of the impact that you're talking about that can happen on innovative and entrepreneurial aspects related to becoming more aging friendly in our local communities. That's the kinds of things the AAAs have been working at. And if we can get support, I mean, that's wonderful to say we have volunteers that can go out and do it. We need to figure out some way that we can actually say at state and federal levels, and I know this isn't the federal level, but well, putting it out there. State and federal levels, we're supporting these local initiatives. Because I will tell you, I got the local mayor where I live said, Joanne, we cannot be sending our firefighters out to pick people up off the floor. They can't be living at home all the time. We don't have the resources to do that. And I'm saying, well, we have to come together, start thinking differently, what we can put together in our communities to address some of these things. It's just we haven't done it yet, but this is a wonderful opportunity to bring it together. But we need to support it.
You're absolutely right. And this is where things start to come together when we look at the big picture, because, you know, Stephanie talked about behavioral health. I referred to Tom in the back and disability, and what you're talking about, Dr. Burke, is essentially crisis, which is a conversation we're having in both the disability space and the behavioral health space. Stephanie talked about CCBHC. So there are opportunities for the AAAs to talk with mayors and say, hey, we've got a solution. We can bring together stakeholders in aging, disability, behavioral health, and figure out how do we put the appropriate resources in place with partnership from the municipality or the county to make sure that there is somebody other than a police officer or a firefighter to help someone who's in crisis, whether that crisis is aging related, disability related, or behavioral health related. But so I think you make an outstanding point, Dr. Burke. Back to the report, and Kelly, what you were talking about. Again, I think this is Erin's challenge, and I hope you've signed her to a 10-year contract, by the way.
I've told her she can't.
No, she can't leave. But I think this, you know, what I have dubbed meaningful and standardized tracking, you know, it's going to take a period of 2 or 3 or 4 years before we get to some of the best data, because if we start tracking it in a meaningful and standardized way, then, you know, a year from this coming July, you know, when this legislation takes effect, and Erin's working on what would that be at that point? The 2027, no, 2026. Yeah. 20, yeah. But I mean, at some point, when you start to have that longitudinal data and you can say, you know, there were X number of hundreds of people around the state whose initial contact with a AAA occurred as a result of an outreach or education activity, and then that led to a home modification. And now a year later, you know, the AAA, through its follow-up with that individual, has reported that the individual is still living independently at home, i.e. Not in an institution, not requiring waiver services. I mean, that begins to tell the story. And that takes time.
Yep, and to your point on the tracking and the home modifications and utilizing an OT and such, well, at Socoa, we're already doing that. And I think I'm gonna try to look at the data that we have and see might be a good starting point. And then if we can get, I think that is part of, we do use a lot of choice funding for the home mods, but the OT part of that, I think is new and is kind of speaking to the innovative part. So I'm also gonna see what data I can put together and share with you on that too, and with you to see what we have.
Do you agree that as a result of the decoupling that I keep teasing but not letting Aaron talk about, that
You're taking your time.
you're going to be able to do more home modification for less money?
I would hope so. That's our goal. And along with a grant that we received from HUD, we're very excited to move in that direction. So yeah, this is all very exciting. So I appreciate the few moments to share.
I mean, I think it's really talked up the decoupling. I think it's time to move to that. So,
I keep teasing it.
so next slide.
This one or the one?
This one. Okay, so the Division of Aging is charged with approving a section of home and community-based service providers for choice based on criteria that we develop. Historically, we have required that the providers be either Medicaid or Medicaid waiver certified, just as our certification, because that was housed within the Division of Aging. There were lots of checks and balances in place, and administratively just made a lot of sense. With this, that does not come without problems, as Representative Clear alluded to, because of the Medicaid or Medicaid waiver application processes. It has discouraged some providers from wanting to even go down the path of exploring becoming a provider for choice. So with this change in the legislation, there are certain services that will still require that Medicaid or Medicaid waiver certification. And these are the more hands-on services: attendant care, home and community assistance, home health, skilled nursing, ones that either require licenses or I think that higher level of oversight. This also enables these providers, who often are providers for multiple funding sources, to have a consistent set of expectations regarding provider certification. So they don't have to do one thing for waiver, one thing for choice, one thing for Title III. With this updated change, there's no longer that Medicaid certification requirement. So in a sense, it has been decoupled from the Medicaid requirements and the services. And this list is likely not all inclusive, but handy chore, home delivered meals, home health supply, home mods, nutritional supplements, the personal emergency response system, home monitoring buttons, and vehicle modification. The code and administrative code still outlines DA certification and provider requirements. So we are in the process of reviewing those and are going to work towards guidance for the AAAs and how to approach this change. But I do think it is an opportunity to open up the possibilities for providers and individuals to kind of step in and help at the community level, wrap around and help people remain independent and stay at home. Questions about that? All right. The 1391 also includes language that FSSA may establish a Medicaid diversion pilot program, looking at the effectiveness of implementing home modifications and telehealth enhanced chronic care services. And it was included for planning and service areas 7, so Thrive West Central, and 9 Life Stream services. to eligible individuals, trying to establish, as we've been talking about, any reduction in Medicaid expenditures. The plan is that I4A in implementing this will work with Notre Dame on a study, and there was no additional funding set aside for this. So the 1391 outlines the importance of seeking opportunities for partnerships, grants, and other resources to help supplement available program funding. So the areas 7 and 9 and all the AAAs will get the allocation they receive based on the funding formula that we utilize. So there will be no reshifting of funds related to the diversion pilot. And I will say, with the passage of the budget bill, the choice program did receive a 5% cut in the allocation coming to the Division of Aging. The 12.5 million out of the total, which is now, I guess, 46 million, is still taken off the top to Medicaid. We are looking at updating, because we had shared what we thought could be the allocations if funding remained level with the AAAs several weeks ago. We're looking at that just with the reduction and just some outstanding questions regarding the non-labor consolidation with the move out of CAMS into the new system, et cetera. So we're trying to finalize the funding for state fiscal year 26. And I don't have a lot more information about the Medicaid diversion pilot, so future meeting, perhaps call on I4A or Jenny.
I've been here the last 2 days, Rebecca, myself, and a few of our staff have spent at Notre Dame.
Can you come to the microphone, Jenny?
No one gets out. You gotta get out.
So I will say without, we just spent the last 2 days at Notre Dame with the Leo group. I will say everything you've been talking about since Aaron got up here has been mentioned. The decoupling, this data, all of it came up the last 2 days. So I know we have a meeting, I think, next week to talk about it. So it includes everything you guys have been talking about, and we've just been working the last couple of days on it. So I don't know how much you want to know or know. I can tell you at this point, that's where we're at, as we just met with Leo. There were, I think, I can tell you there were 6 or 7 groups there. We were the only one from Indiana, because they do groups and cohorts. I do know I talked to the Arkansas. They had a group there looking at some different stuff, and the gal who does, she's over all kinds of stuff, including waivers. She was very curious. She's very interested to see how our project goes. So it's kind of cool to talk to another state.
For the benefit of people watching on YouTube, will you please introduce yourself?
Oh, yes, who I am. So Jenny Hamilton, I'm actually the CEO for Area 9 Livestream Services. So,
Which is one of the 2 areas that was identified in House Enrolled Act 1391 to be part of the pilot.
yep, and we were a little unique because the projects have a decision maker and we have co-decision makers. So Ryan and I are both kind of involved in that. So it'll be fun.
As Aaron said, the pilot is going to have to occur within existing resources, and with the 5% reduction, it's going to be even harder, but I'm confident that Area 7 and Area 9 can execute and prove the concept in partnership with Notre Dame. It is going to require a lot of, as to use the 2 of the words of the day, innovation and entrepreneurism, including leveraging partnerships, which I think you're already working on. So we'll be excited to hear more about that in the future, but I think you're going to help lead the way. So thank you for stepping up.
It'll be exciting. I'm excited.
Okay. Last thing I wanted to talk about in detail is language regarding the Office of the Secretary may, in collaboration with I4A, study and prepare a report containing recommendations for realigning and consolidating the AAA's planning and service areas. So we're talking about the AAA map. There are federal and state processes to go through under the Older Americans Act and in Indiana code to implement a redrawing of the map, and that can take multiple years. If and when we go through this process, the statute includes language that we need to do so in collaboration with you, the Choice Board, with the Commission on Aging, and with the DDARS Advisory Council. So it will be a collaborative process. Federal requirements and state requirements as well require a lot of stakeholder engagement and public feedback and hearings. So
Just for clarification, I know this is a federal, a lot of this is coming out of the federal requirements through OAA, I would assume.
yes, that drives the.
So we have
implementation process.
16 planned service areas in Indiana. Do I have my language correct there? And currently we have 15 AAA serving the 16 planned service areas. So
Yes.
what this is talking about is not, I don't want to stab anything, including myself in the heart with what I'm going to say, but let me just ask the question. So it's talking about reducing the number of planned service areas. I mean, right now, the way it is, more than one organization can handle more than one service area. We're not talking about that. You're actually talking about changing this planned service areas.
Yes, so changing the boundaries of the county configuration.
Realignment is the term that I've used. I think realignment, any conversation about potential realignment necessarily will include conversation about potential consolidation. I said during the legislative session, and I've said a number of times over the years, that despite what some people think, when Moses came down from the mountaintop, it turns out that one of the tablets did not have school district boundaries on the back of it, and the other tablet did not have AAA regions on the back of it. So we can have these conversations. We can and should have these conversations. I believe some of these conversations should have started a long time ago. I know maybe the secretary's as super excited about this as the AAAs are, but I think everybody may come together and have a really constructive conversation, because I joke about the boundaries not being chiseled in stone, but I mean, how many years ago were these boundaries drawn?
Mid-70s.
Hannah's literally hitting her face. Oh, like literally pre-Hannah, not pre-Hannah being the interim executive director of I4A, but pre-Hannah being on the planet Earth. Right. So I just think it's important to have those conversations, and I have, I've made observations about things that I see on the map, but I'm excited about all of the appropriate stakeholders coming together and talking about, how could the map be modified to make the AAA network and the individual AAAs stronger and better able to serve the communities they serve, as well as partner with state government. So there's no secret agenda. Nobody has any, I certainly haven't drawn a map, and I don't think anybody else has either. This is just to start a conversation, hopefully, if and when appropriate.
And the Older Americans Act requires there to be at least one state unit on aging, and the rest is up to the state to plan. Am I correct on that?
So there can,
there are states that there's
a single.
there is a single, not saying that's where we're going, so don't.
I'm not acting out of this.
I'm saying that because I know if it came out, I'm out. It's not. I'm not saying, I think to your point though, and I'm going even pre my journey with the state.
Mhm.
Anytime we begin to discuss things like this, I believe our minds go to certain places.
Mhm.
Is it 1? Is it 2? Is it 10? Is it 20? It isn't really, to your point, about removing any particular AAA.
Mhm.
It's not about removing local access. One entity can make sure that there's locally knowledgeable people throughout the state.
Right.
So it's about discussing how do we improve consistency? How do we help all of the AAAs be more efficient? Coming from leading a mid-sized nonprofit, there's opportunity there to leverage and share. So I think just having those conversations to improve, I think the experience for the entity, but really the experience for the end user. So I'm looking forward to it. But it will be a lengthy process. It's not something that's.
Oh, absolutely.
It's not gonna be done overnight, so.
Yeah, but I think this is an opportunity to really talk about and celebrate and strengthen that community competency that I described earlier. Recognizing that there is tremendous value in having AAAs with community knowledge and relationships rather than having one statewide entity. So it's another opportunity for the AAAs to talk about what they do and find ways to do it even better.
And for the state to find ways to support what's going on at these regional and local
Absolutely.
more
So,
closely.
so Hannah may not have been here when the AAAs were drawn, but she's here now.
And I do think when you say that, I get really buoy, not only in my position, but as an individual. Because it really does and always has started at the local level. From someone that did that forever, you're successful because you know the person next door, you know the CEO of X, you know the folks at the Kiwanis, you know the people in your neighborhood, you know how things work, you know how to leverage that. That needs to feed up, not the other way around. And then the state's role, the way I look at it, is to be foundational, to support that, to augment that. Now, can't be, for a lot of reasons, the answer. It's what is it we need to do
Yeah.
through resources, policy, whatever, to support that happening. And I think it really is. It is a different way of looking at than perhaps we have in at least recent history. I think it is in some ways, because I was here pre-70. It's always a little thing popping around. But I think it is in some ways a return to from where we came. You're really kind of looking at grassroots, but what is the role then of the state in these public monies
Support
to
it.
to
And the
support,
policies to
not be the answer.
support it,
Yeah.
but we have to
Yes.
support it, and that needs to be in our reports.
Yes, and I think that is the opportunity that lies before us as a state agency, before this board, and I think it's a wonderful opportunity for the AAAs.
Well, I'll just say I don't know what the AAAs are thinking, because often we ask them to do things and they don't get funding for it. So that kind of can't help. So we need that's the supporting of what goes on. But we're moving along, and as I think about this legislation that was just passed and think about what carrying forth this multi-sector plan on aging, this is about the best part for the AAAs I've heard in a couple years, I would say, in terms of what are we going to do to support what is going on after they got out of case management and a few other things with the Medicaid waiver group. So it's a new day. I just, I hope the support's there in whatever way we can do it, because otherwise, I mean, boy, at local levels, folks are just struggling to know, well, what are we gonna do now?
Well, I
They're
think,
not
I
doing
mean,
it that way, you know?
at least the current intent, and, you know, please challenge me if this is not the case or your impression. I think the move that we're making now, I mean, as we're moving, you know, we've talked about level of care, obviously that's transitioning away. We have within the reductions, obviously the budgetary reductions. Our plan is to continue to leverage the AAAs and to hold those contracts as whole as we can. In light of obviously the budget reductions, I mean, we can only give out as much pie as we got, right? But that, I mean, that is the strategy at this point, is that the Division of Aging is the State Unit of Aging is leveraging the AAAs as the recognized entity, because it is about building the local communities, and how do you do that? And I can't, you know, even though I don't live in Indianapolis, I can't do that from Indianapolis.
Mhm.
You know, I live in southwestern Indiana. You know, Indianapolis doesn't know southwestern Indiana, or it doesn't know northeastern or southern, as do someone in southwestern Indiana doesn't know Indianapolis. So it goes both ways, but that's really the goal, and I think I credit Aaron and the AAA team and I4A. They've really been working together in a group. We've had some working sessions to figure out how to do it differently than we've been doing it. We need to do it better.
Really appreciate all the conversation. I will send out the slides, but I'm going to turn it over to Vanessa to give an update on adult protective services, since some changes are coming in July. But thank you all.
We just got all kinds of fun things going on, don't we?
Never a dull day, I'll say that.
That's right.
Hey, thanks so much for having me today and for having me back today for some of you. So if we haven't met before, my name is Vanessa Convard. I'm the Service Enrichment and Advancement Director for the Division of Aging. And one of the programs that falls under my purview is Adult Protective Services. I was hoping to introduce you to our new Adult Protective Services Director, but unfortunately she had a prior engagement and had to leave. But she will be back in July when we come back to talk to you some more about what's going on with APS. So you'll get a chance to meet her then. So the big thing I'm here to discuss is that come July 1st, we are switching to a new contract with Adult Protective Services. This is the first time that this has happened in the history of APS with Indiana. So we are moving away from the current criminal justice model, where we have contracts with different prosecutor hubs across the state, and we're moving towards a social services model. I will get the links and all the information out to Aaron and Rebecca to get to you later. So if you want to deep dive, you want to read the award letter, etc. But the short version is that the new contract will be with PCG Indiana, which is a subsidiary of PCG, which is a national organization. And the award letter just went out a couple of weeks ago. So we are in the process right now of getting all of the details of that contract together so that we can get this transition to come July 1st. So we've got a really short timeline, but we also have a really amazing team. So we are getting all of that together now. Some key things just to keep in mind. So that RFP, again, that the award letter is available online, so we'll get you that link so you can look over it specifically. The budget is essentially the same. Our current focus, especially with our shortened timeline, is on our standard operating procedures, making sure that those are ready to go, which are very nearly finalized. We are in the process of developing that new model with PCG. So really taking a look at the new APS federal rule that is going to be active soon. It is active now, but that we soon have to be able to meet. Taking a look at that, comparing that to what we're doing now. What is it that we need to shift to ensure that we are doing our best to meet those new regulations under CMS? It's based on the best practices that are available from NAPSA, which is the National Adult Protective Services Association.
We are also working on a stakeholder engagement plan so that we can get this messaging out to all of our key stakeholders, as well as get information from all of our key stakeholders. And we are also working on finalizing our training plan. So we already have a training developed, but we're just putting the last logistical pieces in place so that we can initiate a train the trainer for everyone at PCG who's going to need it, so we can get that out there and get everybody trained. And I think that is the short version. So any questions? Okay, all right, well, you know how to contact us if you have any questions in the future. Again, we will be back in July to give you a new update on how things are going. Thank you so much.
All right, then I said, thank you so much. Anna. The interim CEO of I4A, giving us a update.
Yes, so thanks for having me. We did wrap up the legislative session this year. There was a little bit of a shortfall, so legislators, including Representative Clear, who's on Ways and Means, had to cut $2.4 billion. So $2.4 billion had to be cut out of the budget, which included what Aaron mentioned, a cut to choice funding as well as dementia care funding. So we're looking at around a $75,000 loss each year for dementia care. But at least we were at the minimum 5%. We could have been cut a lot more, like other line items were cut. We already discussed the choice bill. There is a article in the Capitol Chronicle around specifically the Medicaid diversion program featuring Representative Clear. So take a look at that. I'm happy to send Aaron the link to that, but it's a really good feature on House and Ruled Act 1391. Also, House and Ruled Act 1297 is the yellow dot bill. So this is targeting the aging population. However, any Hoosier can request a yellow dot package from the AAAs or the BMV starting July 1. So you would put the yellow dot sticker on your rear window, and that will alert first responders that you have important medical information in your glove box so they can assist you even better. And so that will roll out July 1st. And then at the federal level, there's a lot up in the air right now. We have been meeting with all of Indiana's congressional delegation, urging them to reauthorize the Older Americans Act because that has yet to be reauthorized. President Trump was the last president to reauthorize it, and so now he's back in office. We're hoping it's not that big of a struggle to have him reauthorize that. However, there has been some reorganization within the Health and Human Services, HHS, where a lot of our services are housed. And so there's a lot of moving parts there. So we're working with new people. However, both parties have said that they don't see an issue with the reauthorization. But we are looking at some major budget cuts. The House Republicans are working on $880 billion over the next decade, mainly targeting Medicaid, and then $230 billion over the next decade, cutting some SNAP funding. So a lot is happening out in DC, and we will continue to keep tabs on that. With the Pathways program, the Division of Aging did reach out to AAAs to help MCEs complete the level of care assessments since they were behind roughly 9,000 assessments. So we were happy to jump in and help, and thank the state for utilizing us as a resource. And then we are receiving word that at least one of the MCEs is no longer moving forward with a contract with at least one of the AAAs for service coordination within the Pathways program starting July 1. And then the last thing I'll cover is the CASOA surveys. So over the past several years, I4A has contracted with Polco, who does the CASOA survey. And those results from the surveys are what the AAAs utilize to make their state plans
based off of that information. The Division of Aging said that those numbers from their data analyst are not aligning with Polco's numbers. And so the state has had multiple conversations with Polco on this matter to see if they can provide some insight on how they got to those numbers. Polco has had some overturn of personnel lately, and they cannot provide that information to the state. So we're kind of in limbo right now, but the AAA state plans are due to the division later this month. And we're utilizing the current numbers that we are utilizing from the CASOA survey. Happy to take any questions.
Comment.
Yes.
You mentioned briefly the revelation that one of the AAAs has been notified that its relationship with one of the MCEs with which it's been contracting will end a year earlier than expected. And I know you and I have both communicated with Kayla Skinner, the interim legislative director for FSSA. I haven't seen anything in response to the questions that you emailed the other day. Are we still waiting on that?
We are still waiting on information from her.
So Kelly, that might be something you want to jump into. I don't know how aware you are of this situation. But it came as quite a surprise that, the 2-year commitment for the 50% minimum of care coordination was not going to be honored. So we have at least one situation now where AAA has been notified that that relationship, that contract is going to end. I assume you're familiar with what we're talking about.
More on the periphery.
Yeah. So I think, as Hannah and I discussed it, we agreed, and I hope that other AAA representatives who are here and listening online also agree that we need to be looking forward more than looking backward. But I think it is important that we understand how we got to this point, because there were some assertions made about, I think, what, Hannah, cost and performance.
Yeah, quality.
Yeah, quality and cost. And I think the AAAs need to understand, if there was a deficiency, why wasn't that communicated, and what was the scope of the deficiency, because I think the implication was that the AAAs were not able to provide the 50% coverage, but at no point was this particular AAA told by the MCE that they weren't providing 50% coverage. So again, we need to look forward, but I think it's also important to understand what happened. And I know I'd be interested in knowing, were they at 40%? Were they at 30%? What coverage level were they at? And if there were quality issues, what were the quality issues? Because that could impact other things going forward.
As I understood the response, it wasn't specifically that there were issues with quality or coverage or anything else. I think that was given as an example. And that the relationship was between the MCE and
The AAA.
and the AAA. So I don't know that that's the reasoning. I think, as you referenced, my understanding is that when Pathways was launched, there was originally the plan that AAAs would provide 50% of that service coordination effort, and multiple things occurred. So that standard, MCEs weren't held to that just because it was not a possible standard to meet in many situations, but recognizing that I think there were at least a few situations where they did contract. So I think it's more on an individual basis, but I'm happy to, take that back and follow up.
Appreciate that.
I'd just like to close the loop and understand what happened, because I think it could inform some of the conversations going forward. And it also underscores the need for better communication. I think, everybody needs to be communicating better, because this came out of left field as a surprise, and that's not good.
That's all I have.
Yeah.
Thank you.
Are we going to, this isn't a question for you, Hannah, but are we going to get the updated waiting list numbers Okay, fantastic.
As a reminder, the waiting list information for the health and wellness and pathways waivers are available online, and Rebecca's pulled out the site, and I will send out the link. Since we last met, FSSA has launched a dashboard where individuals or their families or even the AAAs can log into a system to confirm that an individual is on the waiting list. So that's, I think, one way to help increase transparency and support to individuals if they're concerns about, am I on, am I not? They can go in, log in and see their name. So Rebecca, would you mind scrolling? I have not looked at these numbers recently, so I will, yeah.
I don't think we just
That's right.
released invitations today, so
Just,
maybe
okay.
won't be up yet. It'll probably
Okay,
be
yeah, can you
tomorrow.
keep scrolling? Yeah, the chart.
This is health and wellness.
This is health and wellness. It would have helped if I looked at the headers before you scrolled.
It's, if you hold on, if you hold on, I will
Thank you.
tell you. I will tell you what is not yet posted, but will be posted.
Okay.
So invitations went out this morning for the month of May. As of May 25, there are 5,360 individuals on the health and wellness waiver waiting list. We issued 200 invitations today to the health and wellness waiver. For pathways, as of May, there are 7,796 individuals on the waiting list. And there were 75 invitations issued today. For that one. That should be posted tomorrow.
So you said there were 200 and 275 invitations issued respectively. Is that the total number of invitations that have been and will be issued for May, or is that just
That's for May. Those are as I reported earlier, we are now reissuing rescinded invitations.
Right.
And I mean, you can see on the website, so the number of invitations issued year to date is more, quote unquote, than the slots that we reported available in July because we are reissuing. Like if people decline for various reasons. So while I think we started with about 8,000 invitations in July, I think it was right around there. I slept far too many days, and I can give you that. You can see just for pathways alone, what's it at, 13,000 year to date issued, yeah. 13,042 people have been invited. We only had 8,000 additional invitations, so that's through just recycling, reissuing, if you will, for various reasons. So yeah, then there'll be one more, obviously in June, and then July is the new waiver year as well as fiscal year, but it's the waiver year.
any predictions for July 1?
I don't know hard and fast. What I will say, just kind of the level set, I would anticipate probably under 8,000. We had 8,000 last year. I would anticipate somewhere, I'm not well under that, but I don't,
You mean under 8,000 slots becoming available?
yeah.
Right.
Like new available. Now, I don't know what we'll end up issuing, how many people we'll invite. because of this phenomenon, 8,000 ended up being 13,000 people invited.
Right.
But, you know, we'll still have to get remainder data for May. And June. Obviously, there's a lot more churn on the pathways waiver because it's older individuals and not to be. Not to be too, I don't want to be insensitive, but more people die, pass away on the pathways waiver, and so there's a higher percentage of turnover of those slots.
8,000 on which waiver?
Probably between the two.
Combined?
Yeah.
Okay. So is there any discussion of applying for additional slots?
Not at this time. We have to have the capacity,
Right.
we would have to assure CMS that we have the fiscal capacity to support the additional waivers. And
Right.
at this time, we can't do that.
Right. Well, and I know there has been discussion in one of our recent meetings about the amount of time you allow for someone to accept an invitation before you cycle that back in and invite somebody else. Have you compressed that timeline at all?
Not yet, you know, we just implemented in January the 180-day timeline.
Yeah.
That takes effect upon issuance of the invitation, not
Right.
from time on the waiting list.
Sure.
Issuance of invitation to active waiver service. We are, I mean, with that, we are now being able to churn
Yeah.
more invitations. I thought it was interesting, the discussion actually that we were having earlier today, excuse me, in Commission on Aging. It has been surprising to me, and as we've been analyzing, and I've been analyzing some of the data, what I would call the throughput. How many individuals that once they're invited, I don't really want that, or I didn't realize I had to have Medicaid financial eligibility. I don't, you know, I'm not doing that. So we are really looking at, and Aaron, I'm gonna credit you kind of working with talking about working with the AAAs and some of the their role in post 7-1. Is how do we better in that first touch point, educate people as to, you know, what are you really looking for? I use the example, I needed support for my mother. She passed away a couple of years ago. We had 4 siblings. I could have moved her to Medicaid. She didn't have a lot of resources and assets, but there were 4 of us. We were able to care for her. It was something we didn't want to do. It was important to her to keep what she had. So we chose to explore other options, and through my local connections, you know, finding private pay, leveraging other opportunities, people in the neighborhood, churches, what have you. But I think really trying to better support people on that front end. So number one, with the limited amount of waiver slots, you don't want to hold those when there's no intent for them to be used, if people really understood the impact of it. So how do we improve that first touch point? To your point, just education as a whole. What does it mean? I think it just parlays with what you were speaking of. Really, how do we get this information out there? We are looking at, you know, can we shorten that timeline? But we also want to be respectful of the fact that it does take some time for, you know, individuals to complete the process for Medicaid financial eligibility. And we wouldn't want to cause too much harm. So we're still monitoring that data, but if we can move it back a little bit, we will, but really want to look at that in a little greater detail.
Have you been tracking when an invitation is ultimately declined? The number of those that, well, first of all, where there's just no response, because I would assume there are some where they just don't respond.
Break down across the whole, different, what I would call gates.
Yeah. Is that something you could share?
With me today.
No, I didn't today, but
Tell you, and I've kind of generalized this, just it's between 10 and 15% that are almost just right out of the gate a declination or perhaps and it could be they've moved out of state or, you know, something of that sort, didn't notify us.
Yeah.
And have remained on the list. But it was higher than I had anticipated.
The number of declines or no contact, no response, or what was higher?
Yeah. Declinations and no response is right around 15%. So
And-
it's pretty high. And then there's multiple other gates, like they never apply for Medicaid, financial.
Yeah, you
Then you have the
mentioned,
folks that are denied. I mean, we're ultimately from
Mhm.
invitation to end. And I'm really still just looking at July, August, September, because I want to make sure we've had a
Right.
chance to get through. It ends up being about 40% of the invitations.
who either don't respond, decline.
No, 40% that. Yeah, okay, you got it. Yeah.
Don't respond, decline, or are ultimately found to be ineligible. So about 40% would be in one of those three categories. So with respect to eligibility, are we not doing upfront eligibility determination?
Functional eligibility, we will be.
But financial
But
eligibility.
financial, it's not a requirement that you be Medicaid eligible to be on the waiting list.
We got two requirements and they don't work together real well.
Lovely.
That's my view.
Well, I'll throw out and thank you for that, Kelly. I guess.
And here's part of the
Yeah.
reason, we've talked about it, should we require it? There are individuals that only qualify for Medicaid because they've been found and functionally eligible for a waiver and have been issued a waiver. There's a special income limit. Therefore, they will not be Medicaid eligible until they've been issued an invitation to the waiver. So to require Medicaid eligibility to be on the quote unquote waiting list
Yeah.
would preclude those
Understood.
individuals participating. But I think we can manage that. We've talked about you know, other ways to move people through that process and educate. I think there's, you'll see my little southern bent here. There's more than one way to skin a cat, as my grandmother would say. So I think just trying to look at it in different avenues, because we don't want to cause harm. Right? And Medicaid, you know, that system, the financial eligibility system, to try to make changes there right now, you know, that would be a lengthy process. So.
Yeah, well, I'm not looking for anything formal, but would you be willing to talk about that data in more specificity at the July meeting?
Yeah, I think I'm comfortable. Again, it's not in a report format.
Right.
This is, you know, looking at on the
Yeah,
backside, but I think, you know, happy to share that, share with you what we're witnessing. I think it was a bit of a surprise to me. I thought the
Well-
throughput would be higher than what it is. So I think we have to find better ways
Yeah.
when particularly now, when we're all in times of limited resources, a period of what I would call austerity. I mean, I think that's just, I'm not making judgment. It is what it is.
right.
We want to make sure that we're getting to the people in need.
Yeah.
And who actually not only have a need, but want the service. So when there's scarcity of resources, we have to be really wise in how we're managing that. So I'm happy to bring that, you know, next go round.
I'm going to throw out a request or a challenge that I've put out there in the past. And now that we're past the legislative session and we have some more experience with the dashboard and everything, I think it's time to talk about it again. And that is, I would love for us to report on the dashboard what happened to individuals who received an invitation and ultimately didn't accept it, beyond the categories that we just talked about, because, you know, there's also some number of people, particularly with the Pathways waiver, who are deceased.
Yeah, I have that data.
And, you know, when it comes to both Pathways and health and wellness, there are people who have gone some other direction in terms of they may have even moved out of state or something else has happened. So if you have that, I think that would be really useful. Do you see a point where we could incorporate that into the dashboard?
I will say I don't in the near distant future because we're refining it.
Yeah.
It's been a bit of a laborious process. Internally making sure that we have appropriate data source, that
Sure.
we're tracking it accurately, that it, truly reflects what's happening. I'm not saying that couldn't be a future state.
Yeah. I just think from a policy making standpoint, it
It's
has,
helpful.
yeah, it has value because, now it's time to start looking ahead to the 2027 budget session. And if there's going to be a discussion about increasing fiscal support for more waiver slots, I think one of the things that would inform that discussion is for legislators to be able to understand what happened to people while they were waiting.
And please, I don't want anyone to think that I'm not downplaying the number on the waiting list, but I think this is where you're going.
Mhm.
And I've worked to relate this to individuals, I just shared with you, 7,000 people on a waiting list. That doesn't really indicate that 7,000 people want to utilize the waiver. And
Right.
therefore, that can be misleading and it sounds a bit shocking. And I actually think I did not answer you correctly. Throughput, it's not 60% go active. It's 40% go active, 60% don't. I think I may have answered you just backward of that.
Right.
So I just wanted to make sure I did. Because
Thank you.
my old brain, I think I just didn't answer that correctly. And so those numbers can be misleading.
Well,
Because we don't screen people, per se to say, well, if you don't think you're going to, or not right now, we're not gonna put you on the list. Because we have folks that's like, I'm gonna go ahead and get on the list. And then, when time is their issue, they're like, I'm not ready yet.
And not all states do their waivers.
They do not do it the
So
same
you
way,
can't
yeah.
be comparing to other states.
It is different, because other states, you're actually, it's a
And
different.
it's not the same, so that is misleading, so.
So I very much appreciate what you're saying, and I think providing that data and providing some clarity about what those numbers actually mean.
Mhm.
Would be helpful. I think for the legislative body, but I also, as I think about providers and communities and trying to plan strategically for support. So.
Well, I think, more information, more transparency benefits everyone. So I appreciate what you're doing to track this and
We're getting there.
yeah, would urge you to continue to refine it, clean it up to the point where it could be reported here and ultimately on the dashboard as appropriate, because I do think it could be useful not only for policy making, but for for other things as well. Now, I do believe that we're going to start to see Medicaid diversion. So, I'm not kidding. I think, this is one of the opportunities, and it goes back to the challenge of modifying the choice report going forward and how do we start to capture that. But I think as early as a few months from now, hopefully we're going to start to have at least a few individuals who have been identified as being at risk and served and prevented from from having to be on the waiting list for a waiver.
Any other questions for me?
Oh, we've been a chatty bunch today.
This
Yeah.
has been
It's been
quite a
great.
conversation this afternoon. I think a good.
Great conversation.
Thank you, everyone. And with that, the choice board meeting is adjourned.